Ovarian cancer is what gave this podcast its name. It's been 7 years since I first heard the term. Believe it or not, I just didn't know much about ovarian cancer before my own mother was diagnosed with it. Back then, I remember trawling the internet, looking for information, for good news, for new treatments, for hope. Maybe it was there, but for me, it seemed just non-existent. The needle on ovarian cancer is not moving as fast as anyone wants. But you know what? It is moving. After decades of being stuck. There's more innovation coming down the pipeline than ever before. And in this episode, I want to introduce you to some of those innovators, people who are deeply immersed in solving ovarian cancer. Who are these folks? What motivates them to push forward? And what's pushing back? Sometimes the challenge is biology, sometimes it's funding. On all different levels, this fight is not for the faint of heart. You'll hear conversations with 3 people in this episode. So by no means is this a complete list of who's doing what in ovarian cancer. But I hope that when you're done listening, you'll get a better understanding, as I did, of the complexity of this disease and the problems it presents. These innovators, they're led by their passion for what they do and their curiosity and compassion for the people who live with and die from ovarian cancer. So we begin with a startup founder, Oriana Papin Zogby.
I am the CEO and co-founder of AOA Diagnostics.
And what does AOA Diagnostics do?
AOA Diagnostics is developing diagnostic tools specifically for women's health oncology. We're doing so by using groundbreaking biomarkers that have never been developed before. And our first test is to be able to diagnose ovarian cancer in a symptomatic population.
So you picked an easy one to start with.
One might say the opposite.
Oriana's company has just developed that blood test to spot ovarian cancer early. The hope is that it could make a big difference to outcomes for women who have the disease. The test measures biomarkers in the blood that change when cancer is present, and then uses machine learning to detect patterns. Although the news of this blood test is relatively recent, Oriana's team has been working on this a long time. I talked to her a little over a year ago on this show to find out what the challenges are in doing this work.
What we're doing in ovarian cancer is different to what anybody has done before. I mean, you know the space. People are looking at screening women that have genetic conditions. People are looking at women above a certain age that are a risk factor. Nobody's been talking about women that go to the doctor with vague abdominal symptoms and the fact that they represent a huge population and the fact that they get missed, right? Which meant educating clinicians that this was real, that this was not women saying that they had too much pizza, that educating the FDA on how to design a clinical study that had never been done before. So we bit off a lot. I am proud to say, often people say you bit off more than you can chew. We can chew what we bit off, but it's been, and it will continue to be an uphill battle. And I think the thing that makes it possible 100% is the team that is around AOA, from the scientists and the clinical team and everybody that's in-house to the advisors and the board members and the investors that are rallying behind us as well.
Tell me, what is the end goal?
The end goal with AOA is to transform women's health. And the way that we do that is by bringing to market diagnostic tools for various women's health conditions, by being advocates for patients, by stomping on the grounds of policy, right? By elevating the funding in the space generally. And so that's sort of our end goal. When we look back, we want to be able to say, you know what, we had a lasting impact in transforming women's health. How we plan to get there is by first developing a diagnostic tool for ovarian cancer. When do we believe that we will have gotten there is that when this product is in the hands of providers and is actively being adopted to be used for patients. It's not when we, submit a publication. It's not when we get our FDA, letter. It's when this is in the hands of providers and it's serving patients. And that requires commercialization, that requires a payer engagement. And so that pathway is one that will require significant investment and time, and we're devoted to that mission.
I'm a physician scientist, which means that I'm a physician who predominantly does research, trying to translate findings and observations from the bedside to the lab and then back to the bedside.
This is Dr. Ernst Lengyel, a gynecologic oncologist who directs the Ovarian Cancer Research Lab at the University of Chicago.
I think some of the strengths of our lab is that we work with primary tissue. Since I'm a practicing physician and since I perform surgery, I get permission of patients to use some of their tissue for our research. And so we use that tissue then in the lab to mimic what's happening in the patient in our tissue culture dish. So we may test novel treatments.
I asked Dr. Lengyel to walk me through the specific areas of ovarian cancer research that his lab focuses on.
Biomarkers to detect ovarian cancer early is one aspect. The second aspect is that we study metabolism. Over the last decade or so, we have found that ovarian cancers have a very different metabolism than normal tissue, and have studied why ovarian cancers tend to go to the omentum, which is a fat pad in front of the bowel. And what we actually found was that the omentum, that fat pad, contains a lot of adipocytes. Those are those fat cells that make adipose tissue. And that the ovarian cancer cells like to attach to those adipocytes or fat cells and then use the lipids as energy source to grow faster. A third aspect that we research in my lab are different models. For decades, the pharmaceutical industry has studied and performed drug searches using cell lines that are cultured on plastic. And we revolutionized the drug search by using primary cells. When we operate on a patient and there's some extra tissue, then we extract cancer cells, adipocytes, normal cells, and then assemble a three-dimensional culture that allows us to do drug screening with their own tissue. Another aspect of our ovarian cancer research is that we're doing what is called spatial omics. It's a technique called deep visual proteomics developed at the Max Planck Institute to ovarian cancer research, trying to understand how protein and gene expression changes in the different compartments of ovarian cancer. And last but not least, we do preclinical treatment studies, which means we take agents that have been successful in other cancers and now test them and see if a new drug that has been successful in lung cancer, for example, is also successful or efficient in ovarian cancer. So we're trying to take advantage of that knowledge.
And in doing this work and in sort of pushing forward with your approach and your vision with the lab, what are the biggest roadblocks or challenges that have come up?
The biggest roadblocks, so ovarian cancer treatment in the United States, it's very fragmented, not always performed at the main centers like ours. I think a second big hurdle is also that while I'm a physician who does research, many of the young superstars, PhDs, they want to go into more basic science, like at the Salk Institute or at the Broad Institute at Harvard. So there aren't many scientists that are interested in ovarian cancer. Most go into breast cancer, lung cancer, prostate cancer, which gets me to the third barrier. There's much more money to be found to study lung cancer or breast cancer than there is in ovarian cancer. Because ovarian cancer is so aggressive, often patients struggle with their own disease. They don't have as much time for fundraising as patients with breast cancer have. I mean, as you've seen, like sometimes every trash can is in pink, suggesting to support breast cancer research. We just don't have that public support that is necessary to increase funding into ovarian cancer research.
And then my last question for you is a personal one. I'm curious about what drives you in this work.
I am a physician, so I've seen so many women struggling and eventually dying from ovarian cancer that just doing over and over again the same thing, doing surgery and then giving standard chemotherapy with carboplatin and Taxol will not yield a different result. So I am determined to use the incredible opportunities at the University of Chicago and the very talented members of my laboratory to really try and make a difference and find something novel that benefits women with ovarian cancer. I feel also as a physician, I'm uniquely positioned to do this because I treat women with ovarian cancer, understand the biology of ovarian cancer. I am in a fantastic environment. If I can do it, many other people won't be able to do it. So it's almost an obligation. I can't just sit in my office, go to everyday surgery, give chemotherapy, and go home. I need to change something.
My name is Dr. Jeanette Boudreau. I'm an associate professor at Dalhousie in the Faculty of Medicine. I'm also the scientific director of the Beatrice Hunter Cancer Research Institute, but you can just call me Jeanette, please.
I once watched Jeanette Boudreau speak to a ballroom-sized group of people at an ovarian cancer fundraiser. There was not a lab coat in sight, but her speech was about biology, cancer, genetics, scientific collaboration, and something called natural killer cells. And at the end of that speech, Jeanette got a standing ovation. In a minute, you'll hear why. Jeanette explains complex science like few other scientists I know, and her work revolves around immunotherapy and those natural killer cells I mentioned. There's a lot of optimism around immunotherapy for some kinds of cancer right now, but not for ovarian cancer, not yet anyway. So I asked Jeanette to explain it all. I want to start here. We're living through a very interesting time in the understanding of cancer and how to treat it. But for ovarian cancer in particular, when we talk about immunotherapies, which, are sort of the big headline in many places, we're not quite there yet. Is that correct?
I think in the case of ovarian cancer, that's a fair statement. So, immunotherapy are these therapies that we're trying to use to leverage the immune system in the fight against cancer. And for some cancers, melanoma, a lot of the hematologic malignancies, these are working brilliantly. And I'll remind you, this is what our immune system is supposed to do. So it's kind of just giving the immune system a boost. In the case of ovarian, the successes really haven't been where we need them to be yet. So there's a good camp of us that are working on those now, but we're still working on them.
Yeah. And so let's dig into that a little bit more. What makes ovarian cancer different?
I think it's a lot of things. I think it's that it's sort of everything all at once. So it's not one local tumor. It's almost always metastasized by the time the patient knows that they have it. It exists in a solid form. It grows in the fallopian tubes and the ovaries, but also the fat in the peritoneal cavities. Then sometimes it's in the ascites form, so it's more of a liquid. So it's kind of like a patient has multiple cancers at the same time. And I think that for the immune system, we sort of need to give it a clear set of directions. And that set of directions is really, really broad in a cancer like ovarian that has changed and grown in so many different ways at the same time.
So it's a bit of a shapeshifter.
Yeah, it's a beast.
Okay, so natural killer cells enter the chat, right?
Yeah. So natural killer cells are like these quiet soldiers that sort of go in, they do the jobs that they're meant to do, and they don't leave a trace behind. So it's been really hard to kind of know what these cells, and I'm going to call them NK cells, but what these NK cells have done along the way. So if I can kind of rewind a little bit, NK cells are my favorite. They're sort of like T cells, which are probably the headliners in cancer immunotherapy these days, because T cells do leave a trace, and we've been able to study that and emulate that. NK cells have all the same sort of killing functions and tumor hunting functions, but instead of having a really specific receptor that lets us see what it's been up to, NK cells don't. They have all these different receptors that they encode in their genome like a Swiss Army knife, and then just pull them out in different combinations to do different things. And within all of us, there's kind of a collection of these receptors. Some are the same between people and some of them are different. And then they interact with other genes that kind of modify. So even, you and your siblings who have been drawn from the same genetic pool, if you will have different natural killer cell functions. And there's imprints in terms of how people respond to cancer therapy, to bone marrow transplant, that all trace back to the genes that their NK cells have. So in my lab, what we're thinking about is, how can we figure out which genes do we want to fight ovarian cancer? Which ones do we want to turn on and off? And the good news is that you can take NK cells and move them from person to person, and that's okay. It's perfectly safe, and there's ways to do this. So if I can identify the kind of NK cells that I want, I might be able to find a donor that can give them to us to help out the patient.
So I love the way you describe it with this Swiss Army knife function. And Swiss Army knives are incredibly useful, but there are also some of the elements of a Swiss Army knife are less useful than others, or certainly, if you don't want to open a bottle of wine, if you want to cut something, the corkscrew function is kind of pointless, right?
Right.
So the inherent there in that sort of multifunctionality must also present some challenges.
What a wonderful way to lead into that, right? Like some of those things are actually, if you're trying to build a new bed, the corkscrew arguably could slow you down, right? So,
yes.
And NK cells will do exactly that. So there's all these receptors that are, they're involved in inhibition. And you might think, well, why have an immune cell that you're going to just turn off? There's a lot of good reasons for that, right? And the biggest one that comes to mind is pregnancy. So there's these really important guardian functions that remember, the mom is going to be not identical to her baby. And so there needs to be these functions that kind of protect the baby so that mom doesn't reject it as foreign, right? Which is what NK cells do.
Yeah.
You also kind of want to be able to turn these cells on and off at will. You don't want them kind of going against every tissue. You just want them going against things that have a problem, i.e. tumor cells or something that's been infected. And so this is kind of part of the selection, right? You don't, in a cancer setting, you don't want to be pulling out corkscrews when you really want a screwdriver, right? And so those inhibitory molecules can actually get in the way. And sometimes when I look at tumors, they're expressing too many of those inhibitory receptors or corkscrews, and not enough of the screwdrivers are activating one. So we're kind of looking to rebalance that. But you hit the nail right on the head when you said not everything is good. And then there's tools that are just useless. So have them or don't, but they're not going to help or hurt.
To draw us to a close, let me ask you this. What is, in your mind, the most overlooked aspect of what we've been talking about today? And you can answer that on any plane, on any level. And where is the inequality that's caused by that being overlooked? Where is that felt most deeply?
I think there's a lot. I think as we move into a world where immunotherapies become the norm, and that's where we're going, by the way, there needs to be attention paid to how much these things cost, both in terms of actual dollars and in terms of healthcare expenditures, right? So for some of these treatments, they work, but they're aggressive and you're in the hospital for a while. Patients can be in the hospital for upwards of 6 months after a bone marrow transplant. Some of these, novel immunotherapies are in the hundreds of thousands of dollars. So that's not sustainable and that's not accessible to everyone. So there's an overlooked aspect in this where, you're saying immunotherapies are great, but we need to pull them to a level where they're available to everyone. Honestly, there are patients in Nova Scotia that make decisions to pursue treatment or not based on the likelihood of bankrupting their family. And, to my mind, that's just absolutely outside of the space of acceptable. So that part is overlooked. The population that can't access these treatments either because of distance, finances, often a combination of both, that part is overlooked. The other, kind of piece that I think is really overlooked in ovarian cancer especially is the quality of life that happens for these patients as they're moving through their treatment. So, as a researcher, we tend to measure things in overall survival or progression-free survival, meaning like the interval of time that the patient remains alive or remains alive without disease. And that's important, but that's not all of it, right? And so I think the physicians are doing a better job than the researchers at this in sort of terms of measuring a quality of life, right? So what are the patient's goals and what can we do? And even if that patient isn't necessarily going to live longer, how can they live better? So obviously the goal is cure. And the goal is, to make those intervals in between treatment as enjoyable and rich and strong as possible. But if we can't do that, then how are we actually meeting the needs of the population in a way that allows them to live their best life in the time that they can? So I suppose if I have a message for the research community and the way we're measuring these, it's that it really is actually important that we answer the important questions, which are not days of life, which are easier to count, but the quality of life that we can have, while, of course, aiming for those cures in the long run.
These episodes were made possible by a grant from the Amy Krauss Rosenthal Foundation, and we'd like to thank them for their support. Check out our show notes for more information on the work of the foundation and all of the guests I talked to in this episode.